So thank you for joining us for today's presentation on Gateway to Healthcare, medical coverage for youth with special needs. I would like to welcome the following representative from Achievable Foundation, the Outreach and Enrollment Specialist, Dale Delgadillo.
Hi, am I on now?
If you are.
All right. Hello, everybody. My name is Daniel Delgadillo, and I am the Outreach Enrollment Specialist at the Achievable Foundation Health Center. Um, and I, me, a little background about me. I am a father of a young man with developmental disability, what they used to call high functioning autism. So I know by experience what it is to be a parent in the and I'm also I've got about 20 years experience within the intellectual disability, developmental disability field, and about 4 years in healthcare, specifically with insurance. So I do want to give you a warning. My eyes will be going up and down because I do more of a paper kind of presentation style, bullet points and things like that. So just wanted to let you know. But I have a pretty horrible memory, so I will be gazing down and up pretty often. But it does keep me on track. So our goal here is to get all this content, because there's going to be a lot of information that I'm going to be throwing at you, and I'm going to try to be as fast paced as I can, so that we can get as much of this information in this video as possible. So thank you so much for the introduction. And um, so today our focus is going to be preparing on young people, right? Young individuals for the inevitable transitions that are going to be coming up in healthcare. So the different agencies, health plans, programs, especially when it comes to insurance. So there's a lot of things to cover. So that's what we'll be focusing on. And one thing that's really important to note is that all this information is kind of geared towards individuals who are regional center clients, but is open to a lot of other people as well. And it's very LA centric. So a lot of this information that I'm giving doesn't necessarily apply outside of Los Angeles County, but most of it does. There's some things that are just specific to Los Angeles, and you'll be able to see the difference. But so just keep that in mind if you are going to share this with anybody. So and there's going to be a few handouts that are gonna be addressed throughout this presentation. So I'll let you guys know about them as we get to those points. So does anybody have any questions at this point? All right, let's get to it. Um, so we're going to first talk about private commercial plans, okay? And when we're talking about private commercial plans, we're talking about either individual or through work. So when I say individual, a lot of people purchase their plans on their own, and they'll just go on the internet and find like an Anthem Blue Cross or a Health Net or whatever, and they'll apply on their own. Another way to get private commercial insurance is through your job. So a lot of people have like group coverage. That's what it's called. And there's typically no restrictions when it comes to like residency or immigration status when you get it that way, if you're able to get it. So the first type of insurance that we're going to talk about is called PPO, and that's a preferred provider organization. A PPO is pretty expensive when you compare it to some of the other types. It is, but the reason why it's more expensive is because it's got a wide network, right? So you've got your in-network providers that's a little bit, size of my head, right? You can get any doctor provider that is within the network, and you're not going to pay more to see those doctors. But with a PPO, you get to actually go outside of my face, right? You get to use all of these other doctors that are not in network, and that's what you pay for. So when people say, "Yeah, I have a PPO, I can go anywhere," yes, you can, but you're going to pay for it. So it's always advisable to go in network if you can. Now, if there's that special doctor that you're like, I heard about this doctor, he's world renowned. I'm going to go with that guy. He takes my PPO. I'm going to pay, that 50% copay. First, I'm going to pay down my deductible, all of this other stuff. And you're willing to do all that, then that's good. That's fine. But just know that to go outside of the network, you do pay more. And um, but the cool thing about PPOs is that you actually have freedom, right? So any doctors within your network, you have the freedom to go to that doctor, and if you don't like that doctor, you go to another doctor within the network, and that's it. You don't have to do anything extra than just that. And regarding referrals, same thing, right? It's to any providers. Now, some like to specialists. So if you've got a specialist who requires a primary care provider referral, that's fine. But with regard to um, you having to get like some sort of extra authorization approved and things like that, it's usually a lot smoother when you have your primary care provider send something to a specialist. It's not there's no not as many hoops that you have to jump through as some other plans do. So, um, in essence, well, let me get to out of network doctors. So I did mention out of network providers. Out of network means that you decided to go outside and you're willing to pay. So typically, the way that works is you have to pay down a deductible. A lot of deductibles are usually they could be 5,000, $6,000 for a deductible. So before the insurance company will even come in to help you, you have to pay down that deductible. Once you pay the $5,000 deductible down, then they'll come in with like a co-insurance and help you out with like maybe 50% of seeing a doctor, right? So let's say you paid $5,000 and your next visit to your specialist is going to cost you $200. You might be on the hook for $100 still after you've paid down the deductible. There's usually a max and that you can pay per year, and that is typically like in the $10,000, $12,000 range. It really depends on your insurance, and I would not be able to go like really deep unless I saw your particular PPO plan. Then I could explain all of that to you. But generally speaking, that's kind of how it works. So, in essence, a PPO is you pay more, but you have freedom to kind of go to whichever provider you want, and you can get to go out of network. So that's the crux of a PPO. Any questions? No. All right. Moving on. So we're gonna go to the EPO. So exclusive provider organization. An exclusive provider organization is almost exactly the same as a PPO without the out of network stuff, right? So you only have what's in here, right? Unfortunately. And that means that you can only go in network. It's cheaper, but that means you just cannot go outside of your network. So that very special doctor, that amazing doctor that's world renowned, that only takes PPO, guess what? You're not going to be able to get that doctor. You're only going to be able to go inside the network. Okay. So you still have freedom. You have freedom of primary care providers, freedom of specialists, as long as they're within the network. And that's it. So the conclusion is you pay a little bit more, not as much as a PPO, but you pay, a medium amount for some freedom. And but you just get you have no out of network benefits at all. Now with an HMO, this is where things get really crazy because most people have HMOs. The majority of the patients that I see, most people, it's the one that a lot of people can afford. And an HMO is a health maintenance organization. It's very low cost when you compare it to an EPO and a PPO, but there's a reason for that. And it's got a complicated relationship with an IPA. An IPA is a medical group. Although it's also known as a medical group. And what it does is that they work together. So the HMO pays for the IPA group, the network of doctors. So my face, once again, we're going to use it as the network of doctors. So actually, my face is now an IPA, right? And an HMO will pay for my face. So I don't know why they would do that, but they will pay for the IPA's use of their doctors. So any providers, specialists, you know, incontinence supplies, things like that, they all fall under the network. So the HMO contracts with the IPA, and they work together to provide you services. And it's a lot more complicated. It's another level of bureaucracy, but it saves money to the consumer. And what it does is now that the IPA is involved, then the IPA has a lot of juice, right? They've got a lot of they got authority over what you can do. This means that if you need to see a doctor, they have to bless it, right? They have to give you authorization to choose that doctor. So you have to go and say, I want this doctor. So they'll say, okay, let's see if he's available. All right, the doctor is available. Now you get to go with that doctor. Okay, then you go with the doctor. You see him or her, and the doctor's like, okay, you're in. You need to see this specialist because I see this problem. Well, before you can see that specialist, the doctor can send a referral to that specialist within the network. But the IPA says, wait, let me see if this is okay. Okay, you're good. So, or no, right? Or no. So the IPA has a lot more control over your referrals, over whether or not you can be seen, because let's say you want to switch doctors from one primary care doctor to another, you cannot just switch. The medical group is the one who gives you the okay to do it and tells you when you can do it. So you can't just switch like, oh, next week I want another doctor. This one's not working out for me. You're gonna have to wait till the following month, to the first of the following month, or in some very restrictive insurances, sometimes you have to wait like a month and a half or two. So this is why it's really important to make your choices beforehand, right? Especially with HMOs, because you, in essence, it's low cost, but you lose your freedom in terms of being able to make a decision right away. And you lose your freedom of choice in terms of providers, and you lose your ability to kind of go to a specialist whenever you want, and you're limited to that network. Okay, so I hope that makes sense. I'm going kind of fast, I know, especially with this HMO stuff. But so I think we're good. Any questions? All right, moving right along. So we're gonna talk a little bit about Covered California first. Covered California is also known as Obamacare, the Affordable Care Act, the exchange, the marketplace. You may have heard all of these terms. They all mean the same thing. It means Covered California. It means that um, that you get commercial insurance, but the government's going to help you pay for the premium, okay, or tax some you get some tax credits. So what do I mean by that? Well, if you were to get a commercial plan, you're going to pay out of pocket, right? You're going to pay um, um, let's say you pay $500 a month. The um, the Obamacare will help you maybe pay, maybe let's say $300. So now you're only going to pay $200, and that's what it's all about. It helps people not have to pay so much in their premiums, um, and it's a really good alternative for people who are, especially who don't have insurance, through work, and are like freelancers, or have their own little businesses, things like that. It's a great option, especially for a lot of young adults who uh, might be under their parents or something like that, and maybe they make too much as a family. Um, uh, it's a good option. But I always help families to see whether Covered California is the best option, or another. So so what's the difference? How do you apply? Well, typically you have to apply over the internet. You can go to Covered California, um, and their website, and check it out. I mean, it's you can even see plans before even enrolling. They've got this thing called the Shop and Compare tool, and you can go ahead and see kind of like what you might be able to pay for the different plans, all the different options. They've got a lot of options. They've got um, HMO, PPO, and EPO. So they've got all of those options, um, and they will help you with depending on how much you earn, of course, up to, I believe it was 400% of the federal poverty level, if I'm not mistaken. Let me double check. Um, that was the last 600%. So they will pay up to 600% people who earn. And so, like, we're talking about a person who's a one-person household, you can earn up to $6,000, $6,300, and they might help you a little bit. Or if you're closer to the zero, to like, then they'll help you more, right? So it really depends. So some people won't really get help, and other people. So it really depends on your situation, if going through Covered California even makes sense for you. So, but the cool thing is that there are people to help you enroll. So you can go to Covered California directly, and they'll help you. There's a number that you can call, and they can help you do that. If you have an insurance agent, you can go through your insurance agent. Most insurance agents do have a Covered California license, or you can go to a clinic that has somebody like me, a certified enrollment counselor. Um, all these options are free. We, me as an enrollment counselor, I get no money for this. This is something that we do as part of a federally qualified health center. It's a free service that we do. But agents, they typically the member doesn't pay, but the insurance will pay them on the back end if they get you enrolled and stuff like that. So there's a few avenues on how you can get Covered California. But really, it's the same as HMO, PPO, everything we talked about before. It's just you get some help financially. Any questions? All right, next slide. So we're going to get into Medi-Cal. Medi-Cal, fee-for-service Medi-Cal, is a slide 13. Um, or the next one, the one that says FFS Medi-Cal. All right. So fee-for-service Medi-Cal. It's also known as original Medi-Cal, also known as straight Medi-Cal, and also known in everywhere else except California as Medicaid. So may have heard any one of these terms at some point. They all mean the same thing. Here in California, we call it Medi-Cal because we think we're special, I guess. I don't know. Everybody else calls it Medicaid except here. Um, and it is something that it's to apply. It's kind of tough to get into. You have to qualify. There's two doors really to apply. One is through the low income door, and then the other door is the disability door. If we're going to talk about low income, you have to qualify under the federal poverty level, which is 138%. So if you're under that threshold, whether you have a 1, 2, 3, 4, 5, 6 member family, as long as you're under that 138%, you're going to qualify no problem. If you're in through disability, you're in through Social Security. So those are the two doors that you can get Medi-Cal under. And after a while, Medi-Cal is one of those things where if you get it through disability, you have to be a legal resident. But if you get Medi-Cal through low income, you don't necessarily have to be a legal resident. You can actually be undocumented. Children up to the age of 19 can get Medi-Cal full scope. And then you've got young adults between the ages of 19 and 25 who can get full scope, but they have to qualify under low income federal poverty level of 138%. So for children, it's 266%, which is really high. And then once you turn 19, it's going to go low. But then once you turn 26, it's gone. So you would have, if you're an undocumented person. Now, with regard to Medi-Cal and HMO Medi-Cal managed care, we'll get into that. But really, with regard to fee-for-service, does anybody have any questions regarding Medi-Cal, like how you get it, what it is? Any questions about it? All right. So now we're going to get into next slide, please. Medi-Cal HMO, also known as managed care Medi-Cal. Managed care, really, you only have one option. So everybody who's on Medi-Cal at some point is going to get pushed into a managed care plan. You have to. It's the law. It's one of those things that everybody has to do, unless you have what they call a medical exemption form. And we could talk about that if we have a little bit of time later. But you might want to make a note of that if you have a question about the waiver, about the exemption form. Sorry, but those are really tough to get. With regard to the Medi-Cal HMO, everybody's going to get pushed into it, but it's the same rules, right? In order to get Medi-Cal HMO, you have to be enrolled into, fee-for-service Medi-Cal. So you can't get the HMO without the fee-for-service. That's the only way you can get it. And so the similarities with regard to HMOs within Medi-Cal. So there's that HMO and IPA dynamic once again, right? Yeah, that's why it's so cheap. Well, it's free for anyone who's in Medi-Cal, right? But I think that's why they chose this particular model, because it's the most cost-effective model. And it's the same thing where it functions the same as Covered California or commercial insurance. You've got the HMO, you've got the IPA, and the doctors within, and you've got really mm, no freedom, right, to choose. You're kind of forced to select a primary care doctor, and any referrals that you need are going to be through the primary. The primary care doctor has to make the referral, but then it has to be authorized by the IPA, and then you can go ahead and see the specialist as long as they're within the network for the most part. There's always exceptions to everything, and that's where we're here. Um, People like us, people like me, who work in the health center, who can kind of guide people with other, really funky situations. But for the most part, that's generally how it works, right? And in LA, there's 6 plans. There's um, there's Anthem Blue Cross, Blue Shield Promise, which used to be called Care First, but they got bought out. Health Net, Kaiser, LA Care, and Molina. Okay. Now, with Kaiser, it's the one plan that you can't just get into. Kaiser, you have to either have been in Kaiser within the last 6 months. So if you lost your job or whatever, or and you're low income, and you had Kaiser like a month ago, and you just got approved for Medi-Cal, you're good. You can switch your Medi-Cal over to Kaiser. Or if you're a child, and you're or like you have a guardian who's got Kaiser, and your baby just got Medi-Cal, or your child, or the person you care for, um, just you can go ahead and put them under Kaiser as well, because you as a parent have them, and you can put them under. So that's those are the 2 ways that you can put somebody under Kaiser. They're very restrictive, but you can do it. All the other ones, no problem. You can just switch over and select one of those plans. Um, Now, with regard to residency, I mean, to applying for one of these HMO plans, like I said, you have to go through Medi-Cal, and then you'll be able to get one of these plans once you convert your Medi-Cal into a Medi-Cal managed care. I know I'm going pretty fast, but we have very limited time, so I just wanted to make sure that I had enough time to touch on all of this stuff. Any questions about managed care Medi-Cal? All right, next. All right, so now we're going to touch on original Medicare. Okay, it's also called fee-for-service Medicare, traditional Medicare. These are the terms that are interchangeable, and it's amazing coverage. If you have Medicare, it's the federal version of insurance, and to be able to qualify, you have to either be retired or disabled, or a disabled adult child of somebody who retired. So there's a few combinations, but really it's retirement and disability. Those are the 2 doors. And the coverage that typically most people get, I won't go into any of the exceptions or all the weird stuff that could happen, but for the most part, once you get Medicare, you get Medicare Part A, Part B, and Part D. And A means hospital. B as in boy is for providers, doctor's office, specialists, and like supplies and things like that. And then you've got D for drugs, right? Prescriptions. Um, and what's the good thing about having Medicare, traditional Medicare, the pluses are freedom. Freedom. You can go to most hospitals, most doctors. They're going to take Medicare. Why? Because the feds pay. right? They've got money. They're, they're happy that you have Medicare. Um, and also the network is like the widest. I mean, it's nationwide. I mean, from all the 50 states. I mean, you have no problem, and the territories and everything. I mean, it's amazing. Medicare is fantastic. What's the downside? It's pretty expensive for the average Joe. There is a the premium that you have to pay for it. If you've got like the Part B, there it's 144 bucks and change. Plus, you have to pay down a deductible, which is really low. That it's not that bad. It's 185 bucks, and then the co-insurance is 20%. So the way it works is you pay your monthly premium. A lot of times they make it easy. They'll just deduct it from your Social Security check, and then you get a smaller check. And then when it comes to paying down the deductible, it's only 185 bucks, and that can be paid down pretty fast. And then the co-insurance will kick in at at 80%, right? They'll pay 80, and then you as the individual will pay 20%. So if you go to the doctor, the visit is 200 bucks. You're on the hook for 40 bucks, right? So that's how it works. Now, how do you apply? Like I said, you through retirement. Both doors are Social Security doors. So the Social Security Administration, you apply through there, and they'll be able to figure out which one you belong to. And it's only available for legal residents. So that's a big one right there for permanent legal residents. Okay. Um, any questions about Medicare? All right. So now we're going to talk, next slide. Now we're going to talk about Medicare Advantage. So if you might remember, Medi-Cal, you could convert it into an HMO plan. Well, same thing with Medicare. There's before I mentioned A, B, and D, right? But there was one I didn't mention, which is C, and C for cat, right? Um, and Medicare Part C is also known as a Medicare Advantage plan. And there's all kinds of Medicare Advantage plans. This past month, you were probably seeing a bunch of them on the commercials, like United Healthcare and um, there's just a bunch. There's a bunch of different Advantage plans. And what they do is they convert your Medicare, which has a wide network, right, into an HMO, right? An HMO with an IPA partnership. And that's an Advantage plan. And what does that do? Okay. Well, first off, you have the option of creating it into either a PPO or an HMO. A PPO, I don't know too many people who have it. It's very rare that I've seen a PPO, but people do have it. And what it does is it keeps your wide network. If you convert it into a PPO, into a Medicare Advantage PPO, then you keep a wide network, but you're going to pay that extra cost. If you convert it into an HMO, like I said, you've got that HMO with the IPA combination. Then there are plans that I've been able to. There's quite a few of them that are free, in terms of you don't pay premium, you don't pay. I mean, the premium you still pay. It will still come out of the check. That's normal, and you'll have a reduced check. But what you won't pay for is a deductible, and you won't pay for the co-insurance. Now it just becomes a co-pay, and co-pays could be $0. Um, so you have a $0 deductible and a $0 copay and this is good for elderly who are who don't have much money, right? Who might not be um, low income, but they're like they could really use the help. This is something to consider for family members with disabilities as well. So these are two good choices. Now, what happens is that there are pluses and minuses, of course, to everything. So the plus is that it's low cost, right? No deductible, no co-insurance, right? And zero in a lot of cases. Um, Now the negative part is you lose your freedom. You you're subject to the same rules as any HMO, right? You've got the doctor who's got to you've got to talk. They'll assign you to a doctor, a primary care provider. Then you have to, if you need a referral, the provider will go ahead and uh, make that referral, but it needs to be authorized by the IPA. All of that same, all of that applies once again. So um, another thing is your network is a lot more limited. You no longer have that nationwide coverage. With an HMO, you're subject to that IPA again. So you went from the widest network, which is the national network, down to a small IPA. So you're really paying, you're trading in cost over freedom. That's really what you're doing with that. But for some people, they have really not too many choices, right? So um, it you you have to decide what's going to be good for you in that situation. Um, so how do you apply? Well, you can't just get an Advantage plan. You have to have original Medicare first, right? Through Social Security, and you have to have A, B. The way it goes is A plus B plus D equals C. That's the only way you can get an Advantage plan. So you have to have all three, A, B, and D, to get C. So I'm gonna just touch real quick on what they call a Medicare supplement, and Medicare supplement is covers that if you remember what we talked about before with fee for service, there's that 80% that Medicare covers, and then 20% that that is a member has to pay for, or a patient has to pay for. Well, that's what the supplement covers. That little portion of 20%, you pay a premium. It's a third option, and you can pay for that. That way, you can have primary Medicare, and then secondary this little premium thing, and it'll help cover, but it's an out of pocket thing. So I don't really mention it because I don't help patients get that. I like to try to find the most cost effective services for them. So I don't have too much information, but it does exist, and that's what it's for. Um, and that's it. Any questions? All right. Next slide. All right. So what we have here is a situation where we got Eugene. He's a patient and he's looking for a doctor, and he doesn't know who to choose. Um, Eugene is the guy with the glasses on the bottom on the left, and he's trying to see who he should have as a primary doctor, right? So one of the things he's just like anything, we're only going to focus on HMO because the majority of the people who have insurance are in this situation, which is the HMO IPA relationship. IPA stands for Independent Provider Association, Independent Physician Association, Independent Practice Association, or medical group. They all mean the same thing. That's why insurance is so complicated, right? Because people are like, why isn't it this thing? And the truth is, yes. And so Eugene's trying to find a doctor. He's trying to decide over Dr. Danny Zuko, Betty Rizzo, or Dr. Craterface, because he's with Rydell Health. He's with the Rydell HMO, right? And he's got all these choices. He also has different medical groups that he can choose from. He's got the T-Birds medical group. He's got the Pink Ladies medical group, and he also has the Scorpions medical group. So this patient, he decides, well, you know what, man, I'm going to go ahead and choose the one that makes the most sense for me is Dr. Betty Rizzo. I really, really want Cha-Cha because she's a world-renowned cardiologist, but I just don't like this Dr. Craterface, man. He's got a bad rep. So if I have to go through him to see Cha-Cha, well, forget about it. I'm just gonna stick with Dr. Rizzo, and I'll just go to Sandy, Dr. Sandy as my cardiologist, and she'll do, right? So it's settled. He chooses Dr. Rizzo under the Pink Ladies IPA. Next slide. So, as I said, insurance is complicated. Uh, it's inevitable to see some changes happen with any relationship, right? So, in this situation, Dr. Rizzo and Dr. Olson, Dr. Sandy, they get persuaded into joining the T-Birds medical group. So now they're part of two medical groups. Dr. Rizzo and Dr. Olson are part of Pink Ladies medical group and T-Birds. Well, what does this mean for Eugene? Well, Eugene now has more options because he likes Dr. Rizzo, but now he can actually see this neurologist that he's heard so much about, Dr. Murdoch, right? Dr. Kanicki. And so uh, he's going to go ahead and make the switch. He's going to switch to the T-Birds medical group because he can have access to both Dr. Rizzo and Sandy, but also have access to this to Dr. Kanicki, which is really cool. So he changes. He's no longer in Peak Ladies. Now he's in T-Birds. All right. So any questions? All right. Next slide. Oh man. So did I mention that things get complicated with relationships? Um, yep. So here's what happened. There was an issue with Dr. Rizzo, right? Dr. Rizzo, and she had an issue with Dr. Kanicki. Something happened. She and Dr. Sandy had some issue with Dr. Zuko. They're like, you know what? Forget about it. I don't want to be in this medical group anymore. So Dr. Rizzo actually changed medical groups. She decided to go over to Scorpion's medical group. And but what's interesting is that Dr. Cha-Cha didn't want to be in the Scorpions medical group anymore. She wanted to go, she actually switched over to the T-Birds medical group. And Dr. Sandy said, I don't want to do anything with anybody else. I'm just sticking with the Pink Ladies. So for Eugene, this is a problem because now he's lost out on Dr. Kanicki. He lost out on Drs. Rizzo and Dr. Olson, but he only has Dr. Kanicki. And he's forced to have, as his primary care provider, Dr. Zuko. So what does that mean? Now he's got a choice. What's he going to do? Is he going to stay with the T-Birds, or is he going to go back to the Pink Ladies and change his medical group? And so this is the kind of thing that happens. So for Eugene, our patient, he has to figure out, what should I do? Should I stick around with this awesome neurologist, or should I go down to the to go back to Pink Ladies? So this is the kind of thing that happens all the time. Next slide. So our uh, our patient Eugene, this is the kind of thing that happens, and this is like a real. These are actual real. This is a real medical group. I mean, I'm sorry, a real HMO, HealthNet HMO. You've got Global Care Medical Group. You've got Optum. You've got Ultimed, and these are all different medical groups. And these are the kind of things that happen all the time. It's happened to us as a doctor's office. It's happened. It happens all the time. So this is something that you in real life that you really have to be careful of, because um, things change at short notice from 1 month to the next, and you're like, hey, what happened to my doctor? Sorry, we're not. He's not in this network anymore. It happens all the time. So so just keep that in mind whenever you're thinking about making any changes, because you always want to call the doctor's office. You don't want to rely on the online, because they always give you the online list of doctors and the medical groups they're under and everything. And when you actually set up an appointment and you get there, and you wasted weeks, maybe a month, to go to the doctor's office, and then you're like, here, I'm here for my appointment, right? The medical assistant will look at your chart and be like, oh, sorry, sir. Um, you're not assigned to this doctor anymore. You're with another doctor. And Eugene, the patient's gonna be like, what happened? I didn't authorize any changes. And they'll be like, no, they lost the contract, or they switched medical groups, or whatever the reason. Things happen. So this is why, because of this complicated relationship between HMOs and IPAs. So that's why I just want you guys to be very aware. And with regard to um, this these patients here, I mean the doctors. Um, in the end, Dr. Rizzo and Dr. Olson, they made amends with the T-Birds Medical Group. So I just wanted you guys to know that there was a carnival, singing and dancing, a flying car, and it was all unorthodox, but it all worked out. So in terms of these doctors, everything's good. So just know that everything worked out. Next slide. So we're gonna jump into this handout here. It's not in color, sorry. So we're gonna do the that primary handout, the colorful one, and we're gonna get into like how to prepare when you're 17 years old. So now that you know all this stuff about how HMOs work, PPOs, and all these crazy things, now that you have somebody who's gonna, if you have a young person under 17, this is what you want to prepare for, right? Um, what type of plan do they have? Do they have a PPO? Do they have an HMO? Um, if they have a PPO, you're good. You're fine. Nothing is really needed. You can just select another doctor and easy peasy. Um, if you have an HMO, that's when things get tricky, because if you have a doctor who's a pediatrician, well, at 18, they typically no longer see anybody older than 18. So you're going to have to transition. If you're not prepared for that transition, then if you have a young person who has difficulty with transitions, who is not good with new people, new environments, this could be a big deal. So that's why it's important to know what type of doctor you have. So if you have a family doctor, of then that's fine, because family medicine means that the provider can see children and adults. The issue is always with a pediatrician. And if a lot of people that I see this with is uh, people who have doctors like at Children's Hospital, things like that. Any kind of a children's hospital. Those are the ones that might have a lot of issues because they just get that hit like, oh, sorry, we don't see kids anymore. I mean, we don't see adults anymore. So you're gonna have to figure this out. Um, and so another thing that you're gonna want to consider if you're a parent um, is your decision making power. You no longer have the the right to make those decisions. You're gonna have to prepare for that. So um, there are mechanisms to help you still be a part of your child's healthcare, and we'll talk about those in a little bit. But there are consequences, so you definitely want to be um, prepared for that. Next slide. All right, so now let's talk about what's going to happen um, at 18. So um, if you if you don't have your things in order, your paperwork in order, if you haven't figured out who you're going to go to before 18, a couple things could happen. A few things could happen. Number one, let's say you're 17, your 17-year-old has an appointment with their pediatrician, and when they meet their pediatrician, they've already turned 18. It's been a month after or a few months after. Um, that appointment will get canceled. So if you took months or a month or who knows how long to get that appointment, then you've just lost that much more time. So you have to be very careful about, vigilant about that. Another thing is wasted time, right? Maybe you took off work, maybe you took off school, something. A lot of people have things to do, and for you to go to the doctor's office and then just sorry, no, we're gonna have to reschedule. That's very upsetting to many people, especially if you have to coordinate so many things with your young person who might have a lot of challenges, right? It's sometimes it's not easy to get there, so it's something you definitely want to consider. And then postponement, like I just mentioned. Now you've wasted your time. You a lot of time went by, but then you're more time. Who knows how much more time you're gonna waste before you can get that appointment because you have to fix the insurance and then set up another appointment. So a lot of time has lapsed between the time that you set up that original appointment to when you actually had the appointment to when you actually will finally get that appointment done. So that's something really important to consider, and it's very frustrating for a lot of families. I live it with them because I'm going through the process with them, and it's really a tough thing to go through. So so at 18, new rules come in, right? So the healthcare decisions, they're no longer for the parent. So there are certain documents that you can use to like with the health plan that a member can say, nope, I give them permission to make decisions on my behalf. They have those kind of documents. Or if you have a very complex situation where the patient is very disabled, very needs a lot of assistance and needs conservatorship. While that conservatorship document is really important to have always on hand. You always want to have at least a copy of it in your person, so that you can share it with any agency or with any doctor's office, because that's going to be crucial for you to help make any decisions. So one thing that's really frustrating for a lot of families is that agencies don't share these important documents. So like if you do have a conservatorship and you gave it to Medi-Cal, but your child has a Medi-Cal HMO like LA Care, they don't share that. So you have to physically give one to Medi-Cal, another one to LA Care. If you've got Social Security, same thing. They don't share. They don't share. Social Security doesn't share with Medi-Cal, and they don't share with LA Care, so or HealthNet or any one of the six plans in LA County. So each one you have to give them a copy. That way everybody's on the same page. Okay, so don't assume that everybody knows everything. They don't. The only thing they really share is very basic demographic information. So they'll share like name, uh, um, social, address, phone number, things like that. But they don't share everything. They just the essential information is going to go from one system to the other. So always have that paperwork on hand. Really important. If you're a rep payee for Social Security, it doesn't necessarily translate into Medi-Cal. They're going to be like, "What? That doesn't mean anything to me." So you always want to have um, uh, any kind of paperwork that says that you are authorized to make decisions, healthcare decisions on their behalf, readily available for everybody. Okay. Um, Also, another huge thing that people don't understand about Social Security is that there's going to be a reevaluation. So at 18, the big thing is that um, they evaluate children from 0 to 17 one way, but once they turn 18, the evaluation is based on their basically their ability to work, their ability to contribute, right? So it's one of those things where you have to be very careful. Uh, I would recommend highly having somebody help with with filling out this documentation. There's organizations. If you're a regional center client, there's the Office of Clients' Rights Advocacy that can provide maybe some like a publication on how to prepare things like that. There's stuff out there, but really you want to make sure that you're prepared for that huge transition. And that one you definitely want to start at like maybe 16 and know the ins and outs of, okay, they evaluated my kid this way, but now at 18 they're going to evaluate them this way. The lens is going to change, and it's going to be a very shorter, it's going to be a smaller window, so to speak. They're a lot more strict when it comes to how they evaluate. So you definitely want to have that uh, in mind way before 18 because it's going to happen. Um, and any questions?
Yes, we do have a question from initials JC. Their
Mhm.
question is, what is the turnaround in getting a conservatorship?
It really depends. The ones, so there's places that you can get them for free, right? And when I say free, they're like a nonprofit, like Bet Sedec. They help people do conservatorships, and they'll do like most of it for free, but one has to pay for um, the forms and all the county stuff. They'll just cover the cost of the attorney fees because it's a nonprofit. If you get an attorney, it might be faster. I'm not sure exactly what the turnaround is, but one thing that you want to consider um, is a conservatorship necessary? Maybe an affidavit might be enough, or so these are things because a conservatorship is a time-consuming thing. It really depends on the need of your loved one, right? So conservatorship might be the best option. It might not be. So think about that. Places like the Office of Clients' Rights Advocate, they're like very client-centered, and they're going to tell you, no, we don't help with conservatorship at all. We're all about the client. But attorneys who do conservatorships will be like, yeah, let's get this done. it's no big deal. It's going to cost you $5,000, you know, or whatever they charge. I don't know. And then you go to Betsetic, and they're neither here nor there. They'll just help you do it. But it's because it's free. I think you have to do classes, and you have to do all these. You know, with free comes time, right? Because free doesn't mean free all the time. Um, I hope that answered the question. I can't give you a specific time because I don't know what it is. It really depends. And now with all this pandemic, a lot of people working from home, a lot of, you know, that really has delayed so many things in so many places. So, uh, but I hope that kind of answered your question. Any other questions?
Uh, yes, we do have Suzanne who would like to ask a question. Suzanne, I'm going to ask for you to unmute yourself.
Okay. Hi, can you
Hi.
hear me?
Yes.
Hi, I'm Suzanne Bennett Francisco, and I'm a parent of three young adults that have differences. And I also work with Disability Voices United. And so I just wanted to make sure, I don't know if everybody can see the chat, but, you know, conservatorship used to be the only thing that was offered. And so parents would say, oh my goodness, I want to support my young adult in being able to make decisions in healthcare and otherwise.
Mm-hmm.
And now that is not the only option. And in fact, it's the most restrictive option. So like you said, I really appreciate what you said. There are resources that people can take a look at that I put in the chat at UC Davis Mind Institute, also at the Office of Developmental Primary Care at UCSF. There's all kinds of tools on how to basically have the person have a circle of support that helps them make decisions. And if I can just say very briefly, supported decision making is just what we do every day. When we go pick a doctor, we never know exactly what the doctor knows, but we know we want the doctor to help us and that we trust this person and they have the expertise. And so we practice supported decision making every day, and we're seen as wise. So basically, supported decision making is letting the person have their loved one or the people that are important to them in their lives, helping them with decisions without giving away all of the rights of that person to the court. And I think often parents think that they're in charge of the conservatorship, when in fact the court is. So we just really want to educate people and let them know that there are ways to support their loved one and help keep them safe and protected and being able to make choices in other ways. So I appreciate you letting me speak about that. And if you need any more information about that, please, I can put my email in the chat as well if you're interested. And you can go to Disability Voices United has a handbook on supported decision making as well, including healthcare.
All right. Thank you so much, Susan.
Thank you.
Thank you.
Yeah, and she touched on the fact that you know, there's more choices out there. So there's not just black and white. There's a lot of stuff. So thank you. So any other questions regarding you know, once that 18 curtain goes down?
Oh, I think we're ready to move forward.
All right. So so 19. So now we're going to focus on individuals who are really mainly undocumented, how this is going to affect them. DPSS, the Department of Public Social Services, is one way to get Medi-Cal, like I had mentioned previously. So this is where you can actually use mine is not in color. Unfortunately, I couldn't get it in color, but this is that countable monthly income, and it shows you for an individual. Like let's use the one one household member at 138%. The most that individual can earn to get Medi-Cal is $1,468, right? So with this situation, once a person who's undocumented reaches the age of 19, things are going to change for them. So it's no longer 266% as a child. It now goes down to 138%. So for this person, we're talking about going down from being able to earn $2,829 as 266% down to 1,468 as a 138% federal poverty level. And what that means is that a lot of people who used to qualify will no longer qualify as an adult. But the ones who do, the low income individuals who do, even if they are undocumented, they still qualify. So they're still good. A lot of times what will happen is at 19, individuals can break away from the family, right, and do their own taxes. And if they earn $0, then guess what? They're going to qualify for Medi-Cal. Or even if they earn, up to $1,000 a month, up to $1,400 a month, they'll qualify for Medi-Cal. For individuals who are developmentally disabled or have a qualifying disability under Social Security, there's another program that they can access, but that wouldn't be these people, because this is for the undocumented community that we're kind of focusing on right now. And that's pretty much it. Any other questions regarding once you turn 19? All right. By the way, this law just entered California. It became a law this year, 2020, where before, once you turn 19, you completely lost out on Medi-Cal, and you were subject to other resources. But what it did is between the ages of 19 and 25, now they can continue Medi-Cal but at a lower federal poverty level. So that's something positive for individuals who didn't have coverage before. So let's go to age 21. What's going to happen? Next slide. So at age 21, this is going to be a rough one. So you definitely want to be prepared if you have a loved one who's on CCS, because it's going to end, and it's really bad. I mean, it crashes and burns. I've seen a lot of patients who just relied on CCS and didn't have a transition plan, and they were just left scrambling. And like I had mentioned, an HMO situation, you have that small network of doctors. Well, if you're used to CCS, the luxury of CCS, and being able to see these other specialists, if they're not within that network of doctors, forget about it. You're not going to see them again. So you definitely want to prepare, maybe ask these CCS doctors, tell them, hey, okay, before my loved one turns 21, what do you recommend? What should I do? Is there anybody that's like you? Because these CCS doctors, usually it's mainly specialists, but sometimes primary care providers, you want to find something that's comparable, right, to what they provide. So maybe during the time of 18 and 21, that could be a perfect time. Maybe even before. It really depends on how you set things up. But you definitely want to have that prepared, because I've seen some really sad things happen, and especially when you're used to your specialist or your primary care provider. With regard to certain mental health behavior programs, LA Care, HealthNet, and maybe some others. If you've got Medi-Cal HMO, you can check your card. On the back of your card, it'll have a mental health number, and on that number you can ask for behavior services. Medi-Cal does pay for behavior services, especially if it's related to autism, right? So those are the kind of things that will end at 21. So make sure that you access those services in time, and know that they're going to end at 21 abruptly. So keep that in mind. Any questions about that?
You do have 8 minutes left, so if you want to wait to hold questions until you're at the very end.
Okay, all right. All right, so here's the big one. At 26, that's it. You no longer can be under your parents' insurance. So that means that um, your loved one is going to have to either find their own insurance, or it depends on the situation. If we're talking about, your typical person who's on their parents' insurance, well, they're going to have to find their own, whether it's individual or group or Covered California or Medi-Cal, whatever it is, they're going to have to find it on their own. Now, if it's a person with a disability, you might want to check if your work allows for some sort of exception, right? If that plan allows for an exception for them to continue, because I've seen cases where it'll go beyond 26 if they can prove that, like with a conservatorship document or some other thing that really is um, that meets the criteria for them to continue after age 26. But those are rare, right? And you have to double check with your with your parents' insurance to see if they can keep on doing that, or with the parents' insurance. And what does that mean for undocumented individuals? That's it. At age 26, they are subject to the acts, right? No longer can access full scope Medi-Cal. So they will revert over to emergency Medi-Cal. Since they have a case, it can be switched over. And what is emergency Medi-Cal coverage? Just real basic emergency coverages, like if they're in an accident, or they go, basically if you go in through the emergency room, it'll cover you. There's other services for pregnancy and other like cancer services and things like that as well, but it's very restricted, which is why it's called restricted scope Medi-Cal. And this is where we'll touch on My Health LA, because that's once they turn 26, that's when people can who are undocumented can access My Health LA services if they wish to. So we'll jump into the next slide. So like I said, emergency. How do you apply for emergency Medi-Cal? Through DPSS. Okay, so you can apply. Well, I would normally say in person, but I guess that's not an option right now. But most people are doing it through their portal online. It's called YBN portal, Your Benefits Now. And if you just Google that, you put YBN portal, it comes up at the top. It's the first thing that pops up, and you apply through there. Another thing is, like I mentioned, My Health LA. So individuals who are undocumented can apply for My Health LA. There are federally qualified health centers who do this. The health center where I work, we provide this service, and there's many throughout LA County. There's a few. There's over 100, I think 200 or something, health centers that help with this. So there's a lot of partners. So if you're close to one, you can apply. And what it does, it provides primary care. It also assists with like labs and just basic care, follow-ups, referrals, and also medication. So it covers a lot of things. It's got a really good mental health program too, for individuals as well. So that is also covered, and it's free. It's only for Los Angeles County residents. That's why at the beginning of the presentation I said some of these services are only going to be. It's very LA centric. This is really what I mean. My Health LA is only in LA County. But it's a really great program for those who qualify. And if they're in a situation where, like, let's say they have to go to a hospital, or they don't qualify for My Health LA, right? Some people just might not for whatever reason. They can request assistance at a hospital. Maybe a lot of hospitals have financial assistance programs. If they can prove that they're low income, they can get a really reduced rate. There might be other programs that they can access. There are a lot of other Medi-Cal programs. I'm just going to touch on a few, but there's a lot that hospitals can help you access. Or if you go to like a doctor's office like ours, uh, federally qualified health centers have sliding fee scales. So a sliding fee scale is basically, it's based on your income and your household makeup, and you can pay a very small copay if you're uninsured, and that's very helpful. So there's a lot of things out there for individuals to access, even if they don't have insurance or if they're undocumented. So and I guess some more things to consider are the what's the next slide there? So we're going to talk just briefly about COVID and how that's affecting healthcare. So that would be this thing. And I apologize for the date. The original date of this was going to be December 8th. So I totally forgot to give everybody change the date. But the information is the same. A lot of people are working from home. So these are the kind of things you're going to keep on seeing from healthcare, including insurance agencies. So whenever you call your health plan and you feel like you've been on hold a lot longer than usual, it's that. I talked to a lot of agents who are working from home. So that's the norm, and that's not only in with the health plans, but it's with Medi-Cal, it's with Social Security, it's with the doctor's office, it's with everybody. A lot of agencies, a lot of programs. So things are going to be really slow. So you're just going to have to be patient. And with regard to Covered California, we saw some extensions with Covered California based on COVID. There were some qualifying life events that allowed people to enroll in the middle of the year that didn't normally happen. I mean, this was the first time it ever happened, and a lot of people got coverage in the middle of the year. So we might see some of that stuff if the pandemic increases, or so we don't know. So this document here is a giant I don't know. Things could change at any time. But same thing with DPSS. They got really hit, especially there. So first, there's nobody really working at the offices, and then everybody going online to submit documentation. They are really overwhelmed. If you try to call during the day, it is just it's the wait times could be an hour. I mean, it's very long. So, but they actually do answer, unless they hang up on you, right? Then you have to call again. But if you're able to, stick to it and speak with a rep, you can get things done. But really, it's all done through online. Everything is that's how it's pretty much all happening. Just like this presentation, right? And you'll see a lot more phone consults, like with your doctor's office. They're going to give you or virtual consults, right? Like video or teleconference, whatever they offer. It's going to be a lot of that stuff. So you'll be seeing more of that. And with My Health LA, same thing. It'll be one of those things where you'll be working with somebody like me virtually over the phone. We can help you out. We can do it all that way. And then lastly, the political landscape. We don't know what it's like. I know that there was a big worry with regards to, politics and, what if the services get cut and things like that. Right now, we don't know. We don't know what will happen. Things could change at any time, especially in 2021. With regard to COVID, right, and how that's going to affect. So you always just want to be mindful, and if you can do things earlier before things change, that really would be the best thing to do. I'm going to go ahead and touch on the gentleman who had mentioned share of costs. What is it? What causes it? Basically, it's income. If your income is above the federal poverty level, but like let's say you still qualify for Medi-Cal services because of your disability, I see this a lot, and what that means is it's got to get fixed, because once that share of cost comes in, like let's say you have a share of cost of $1,000 a month, right? You have to pay that down before Medi-Cal kicks in. Well, that's like not having insurance. So why even have Medi-Cal, right? So if you can fix that share of cost, um, uh, and be able to be seen without having to deal with it, then that's the best thing to do. So I can help with that. That's the kind of thing I help our patients with, or figure out other options depending on their situation. There's a lot of things that they can access that might be able to help. The 250% Working Disabled program, that is for individuals who have a disability, a Social Security qualifying disability. That means it doesn't have to be a developmental disability. It just means Social Security uh, eligible. So, and those individuals, they can increase their federal poverty level eligibility from 138% up to 250%. Of course, there's criteria, there's rules, blah, blah, blah. But if you can get this 250% Working Disabled program, then you're good. You pay a premium. There's a sliding fee premium, but whatever the premium is, it's a lot better than not having coverage, Medi-Cal coverage, because the Medi-Cal coverage is full scope. It's if you know anybody who has Medi-Cal, it's a really great program. I know I was talking about the HMO IPA, lack of freedom, but when you don't pay much for that level of service, it's fantastic. It's really good. So I don't knock Medi-Cal at all. I think it's a wonderful program, especially for those who can't afford it. In-home supportive services. So I'm just going to touch on this real quick. In order to have in-home supportive services, you have to have Medi-Cal. That's the criteria. So everything we talked about Medi-Cal, and if you have both Medi-Cal and IHSS, if you lose your Medi-Cal, you're losing your IHSS. So you have to keep that Medi-Cal in place, and you don't want to mess with it. You want to make sure that it's and the share of cost, guess what? It's going to affect the in-home supportive services. So you want to make sure that all of that is squared away, because anything that's linked to Medi-Cal is going to affect anything else that's linked to Medi-Cal. With regard to Denti-Cal, same thing. Denti-Cal is Medi-Cal's version of dental care, right? And there's other programs besides Denti-Cal that you can choose from, but Denti-Cal is like the big one. It's the main one. It's got the biggest network of dentists. So whichever one you choose, you want to make sure that your Medi-Cal is in order, because if you have a share of cost, it's going to affect your Denti-Cal like it affected our caller earlier. So these are the things that you want to make sure that you have. Now, presumed eligibility. I'm going to touch on two, the two that we mainly work with. CHDP, which is for children who are presumed eligible for Medi-Cal. So every child is presumed eligible if they qualify under the 266% federal poverty level. So if for whatever reason their Medi-Cal is inactive, or they don't have Medi-Cal, but they need to see the doctor right away, there's a mechanism. Doctors' offices, mainly federally qualified health centers, have this ability to make the Medi-Cal active for 1 month or a little bit more than a month, and get it activated, and it gives the parents that much time to go and apply for Medi-Cal. That way, there's no lapse, right? You started with the doctor's office, they activated it, and then that gives you just that much time to formally get it active. And the doctor's office will give you the paperwork that you need to give to the DPSS office to get that done. Same thing with Every Woman Counts. Every Woman Counts is a program for women under 200% of the federal poverty level, and this program is specifically for cancer screenings. So whether you have a job or not, if you're under that 200%, you should qualify. And you could actually just Google that, EWC, Every Woman Counts, and they'll, all the criteria is right there. I mean, our doctor's office has people who can assist with that. And it's an amazing program, fantastic. So all these programs are great when they work with one another. I'm going to touch on gottransition.org. That is what I had mentioned earlier on about a website or a place that you can go to for in-depth information about how to prepare. I only touched on it briefly, but these guys go real deep. I mean, they've got all these great tools that you can use to find that. Excuse me, I'm going to drink some water. And what gottransition.org does is they don't focus on insurance like I do. My presentation is really about, you know, LA and regional center clients mainly, and insurance, right? And it touches on some of this other stuff, but this goes real deep into how to prepare, and it's a wonderful resource. I just found out about it recently, and I'm so thrilled. I'm really happy because they got it right, and it's very family friendly. It was one of the agencies that was a part of it is called Family Voices, and that's a national organization for people who have loved ones who have special healthcare needs. So it's a great program, and I highly recommend it. And then at the end, we'll just touch on the fact that we created a terminology list of kind of general terms that you'll see in both special needs and also healthcare. These are the kind of things you'll see pretty often. So if you bump into any acronyms that you don't know or terms that you don't know, these are kind of generally what we decided that is going to be something that would be useful. If there's anything else, we don't mind adding to it, but generally speaking, it's kind of a pretty good a list of what to know. And I think that's, we're going to touch next slides. Sorry. So we have a lot of people who have Medi-Medi. What is Medi-Medi? Medi-Medi is Medicare and Medi-Cal, and there's all kinds of versions of that. There's there's people who have straight Medicare and straight Medi-Cal, people who have Medicare with a Medi-Cal HMO. There's a Medicare Advantage plan with a Medi-Cal HMO. There's CalMedi Connect bundled plans. There's Medicare Advantage SMP plans, which bundles them too. SMP stands for Special Needs Program or Special Needs Plans. So there's so many different variations. It doesn't matter what the variation is. All it means is that you have both Medicare as primary, and then Medi-Cal. So when we talked about Medicare, If you remember, we talked about the 80% that Medicare covers, and then there's a 20% left over. Well, Medi-Cal, it comes in and provides that 20%. So you have a whole, the Medi provides that holistic coverage, right? So it's really good. If you're able to get Medi, oh, that's it. That's the holy grail right there. It's fantastic. Now, there's also other combinations. There's commercial plans with Medi-Cal, right? So some people have PPOs with Medi-Cal. And with PPOs, there's always a kind of a similar dynamic where, like, let's say you've got a PPO that covers 80% and you've got the Medi-Cal, you've got that holistic thing, you've got full coverage. Let's say you have a commercial HMO with a Medi-Cal HMO. You always want to, make sure that they're compatible with one another. What I mean by that is if you have an HMO commercial plan with a different IPA, and then you've got Medi-Cal with another IPA, that can be conflictive. So you always want to double check that. A good enrollment counselor should be able to help decipher that and clean that up for you. Because if you do have an HMO commercial plan or a PPO commercial plan, that actually triggers you to be able to convert your Medi-Cal back to straight Medi-Cal. So there's ways of doing that so that you have a very clean insurance, right? You want to have the least amount of bureaucracy as possible. You don't want to give yourself a headache. You don't want to give your doctor's office a headache, your specialist. If you have just the plan and straight Medi-Cal, it's the cleanest. And of course, you want to make sure that your doctor's office takes both, right? Because if you have a doctor's office who only takes your commercial plan but doesn't take your Medi-Cal, then you're going to pay out of pocket. So health centers like ours take both. So we'll take the commercial plan and also the Medi-Cal. And this also works for Medicare as well, right? So like I mentioned before, the Medicare covers the 80%, and then the Medi-Cal will come in with the 20%. So it's the same situation. Now, sometimes you got too much insurance, and people have been mad at me and told me, what do you mean too much insurance? You better know what you're talking about, and blah, blah, blah. I'm like, hold on. There's a reason I say that. And the reason for this is it gets really convoluted because most plans cover, with two plans, you've got it. You've got the 80 and the 20 or something similar to that, right? When you've got triple, you have to, a lot of times, like let's say you've got a Medicare and then a PPO and then a Medi-Cal, a lot of times the Medi-Cal doesn't even come into play because you've got too much insurance. And you've got this wonderful free insurance. And if you've got Medicare, it's typically not very much. And then you're paying for this primary insurance or the Medicare or the commercial insurance, one of them you're paying for nothing. So really you're just giving your money away. So that's why it's not for me, I think you're just giving your money away, and it complicates billing for any provider, right? What's good about it is that you've got this sense of no matter what, somebody's gonna pay for something, but sometimes it's hard to find out who's on first, right? Who pays, who's primary. If you've got two primary plans like a Medicare and a commercial plan, sometimes it's tough to find out who's primary and who's secondary if you've got a tertiary. So so it's not necessarily better to have three plans. If you've never had any problems with it, then that's fine. But you might be giving your money away. So it's something that you definitely want to consider. I'm not saying it's bad, and I'm not saying it's good. I'm just saying, something to consider. And one more thing about the Medi that I forgot to mention. So for Medi plans, what's awesome about Medi-Cal is that the Medi-Cal will pay for the premium, that $144 and change, zero. It's going to pay for the deductible, down to zero. It's going to pay for co-pays, zero. So Medi is like, you won't get deductions on your check. You'll have full super full coverage. It's like it's wonderful. It's really good. So it's the plan to get if you do have it, and or the dual plan to get. And I think that's it. Any other questions? I guess I could go into that last slide. My name is Daniel Delgadillo. I am I work at the Achievable Foundation. We're a fairly qualified health center in Culver City. We're actually co-located in the same building as West Side Regional Center, and we have a wonderful relationship with West Side. And the one thing about the services is that even if members, if clients are not regional center clients, it doesn't matter. We can, me as an enrollment counselor, I can provide free advice, guidance with regard to insurance. And I'm available to help. So that is something that we do free of charge. And it's that special relationship that we do have with Westside. And that's pretty much it for me. Thank you so much for your time and for letting me just go crazy with all this insurance stuff. I know it's very dry information, but it's really important, especially if you have loved ones who could experience some really difficult situations just by not having their insurance set up properly. I've seen some really bad stuff, and I wouldn't want that to happen to any of you. So thank you so much for sticking around. Appreciate it.
So that concludes our presentation. Have a good night, everyone.